I don't know if you saw this one, Amina, but this is the clinical practice guideline we published in 2020. These are guidelines that come out from the academy at regular intervals. Um, I've been on several of these, and just by way of a little update, the Bell's palsy one, I was on that. We published that in 2013. So I've been commissioned to chair the updated guideline for Meniere or for Bell's palsy, which we're working on now. That'll be coming up, but we'll still cover that one in the next couple of weeks, with the caveat that there's been a lot of research in that area. But so this one came out in 2020, and the whole goal is to take the modern day literature and to make recommendations based on the strength of the literature. So everything we say here is not it's not biased necessarily. It's reflective of the literature of the day. And certainly there are some components to this that may be best practices based on preferences by providers and whatnot. So that's where it'd be good to get, Brad's take on this as well in terms of, maybe some nuance, because some of the things that we talk about with Meniere's, there's still things we just don't know. So there's definitely some provider variability on how things are managed. So this is just the guideline group. So we know it's pretty common, affecting 50 to 200 per 100,000 adults. And then you can see the prevalence worldwide. I'm always interested to see this because the diagnosis of this, as you'll see, and as you probably already know, is challenging because it can be confounded by other disorders, i.e. vestibular migraine, which is thought to be the great mimicker of Meniere's disease. So many times folks may have a concurrent or an overlapping diagnosis of something else, or it certainly could be in isolation, but many times, because this is an episodic disease, it's challenging to many times on the first pass, unless it's classic presentation, to make a definitive diagnosis. So it kind of commonly affects more middle-aged folks, can be bilateral, which creates, and we'll talk about that later, a bit of a clinical conundrum and how do you manage these folks, especially if you talk about ablative versus non-ablative approaches. You have to be very cautious about doing irreversible damage to someone's inner ear, particularly if they have contralateral disease. So you have to be very thoughtful before you do anything that could be irreversible. And then there's still a slightly higher prevalence in women that's been established. So this is just the target of the guideline. Here's some stuff. So we'll just make some statements, recommendation. Again, this is just a reflection of the strength of the literature. So classic example here. So I may put you on the spot a little bit. So you have a middle-aged person comes to the ER because they have a random attack of vertigo. Okay. So not uncommon, right? Probably the bulk of the people that come to the ER are going to have some kind of maybe balance disturbance, or if they're coming to a primary care provider's office, most of the time they're coming in with a headache or some kind of balance problem, right? So this is kind of a classic presentation. So how do you proceed? What kind of questions do you want to know? What kinds of things do you need to find out from this patient?
So I need to find out duration of the vertigo, and I try to ask them to use other words other than vertigo. Is it spinning? Do they feel like they're collapsing? To try and establish if it's a true episode of vertigo or not. So I'll ask, is it spinning? Does the room spin? Do you feel like you're falling? How long is the episode? And to try and ask them exactly what's happening when you feel you are dizzy. Do you have deafness during that episode? Are there multiple episodes occurring together, or is it just one episode and then you're feeling very terrible after that? Many times they might not be able to give you the exact duration, but at least they can estimate how long that's happening. It's also important to ask about position. How did this start? Were you in a position that is dependent, bending up, looking up on the roof? Were you turning in bed? Or did something hit you on the head and you get dizzy? We'd also want to ask about other associated symptoms, so noise in the ear, hearing loss, headache, or if they have any migrainous headache or any other headaches that they might have. We'd also want to ask about vomiting and nausea. If it's just nausea or are they vomiting? I want to know, is this the first episode they've had? Have they had previous episodes before and how frequent the episodes are happening? So is it multiple episodes in a day? Or is it a very bad episode every once in a while in a month to try and narrow down the diagnosis? I also want to ask about vision. When you have the episode of vertigo, are you having double vision? Do you get blindness, unable to see? Do you have weakness elsewhere in the body? I'm trying to rule out possible central causes to their episode of dizziness. I would also ask about comorbidities, hypertension, any systemic illnesses, previous neurological issues that they could have had in trying to know if this is a true episode of dizziness or not.
Mhm. Yeah, it's excellent. Good work. Yeah. I think you touched on two real important things. One is many people they miss kind of when you talk about people use the word dizzy all the time, right? And so
Yeah.
dizzy is not a helpful word. So I really hold the patient accountable to be very specific about the descriptions of their balance attack or balance state. Because many people use the word dizzy indiscriminately, and dizzy could mean several different things, right? So it's really important to steer people away from that and be very specific. Vertigo would portend a rotary sensation, sort of either a patient's stationary and the world's rotating there, or they're rotating around the stationary world. Regardless, there's some kind of a rotary kind of a feeling to it. Um, and then the other thing you touched on was really important for this is, are there concurrent otologic symptoms? Fullness in the ear, roaring tinnitus, fluctuations in low to mid frequency hearing. Um, yeah, that's great. That's all critical. And then, just the timing is really important. Head position, you mentioned that. So that's excellent. Good. So guideline number one, as you can imagine, clinicians should diagnose Meniere's in patients presenting with, and you mentioned timing on these things, is two or more episodes with vertigo lasting at least 20 minutes to up to 12 hours, which would be defined as definite, or as the Baronese Society would talk about, maybe, or up to 24 hours probable. But the issue, then we start stretching into other things we'll talk about shortly. With fluctuating or non-fluctuating hearing loss, tinnitus, pressure in the affected ear, or when these symptoms aren't accounted for by something else. So it's really kind of getting at this idea that the Meniere's disease really is still a clinical diagnosis. And we're making big strides in imaging and physiology to sort of drive home the diagnosis, but still at the heart of it, it's still a clinical presentation. And so they have to really meet these criteria um, to have that. So that's really important. So a really good history with focusing on these types of presenting symptoms is critical. Okay. So you have a 35-year-old comes to ER, spontaneous vertigo, lasts less than 10 minutes, but then can go on for well over a day. And then they might have some mild, vague, subjective fullness or tinnitus in the ear. But so by our criteria, is this Meniere's disease? And if not, what other things might you consider?
It's possible to be Meniere's. It could be a probable Meniere's disease, but other differentials that I would consider would be a vestibular neuritis or labyrinthitis, given the duration of the duration of up to 36 hours. That would be a differential that I would want to roll out, and both of those would give us subjective otologic manifestations.
Mhm. Yeah. So it doesn't quite meet the criteria that we just talked about, right? So it makes you think, okay, is the patient being accurate on their description, which is oftentimes something you have to really double check. And that's where I always have patients that I've established care with keep some kind of a log, a dizzy journal, so to speak, because many times people have a hard time remembering the specifics of their attacks. So if they kind of journal them, they can write this down and they can refer back. It's helpful. But regardless, some of these, if this is going either less than the recommended or the required time or well beyond, you're right. There's some other things to think about. So, so one of those is migraine, right? So we've learned that the great mimicker of Meniere's is vestibular migraine, and I think the field is slowly understanding that this might be an underdiagnosed problem, and that a lot of folks may have it, and it becomes almost like this, catch-all diagnosis that, but it could, still explain a lot of symptoms, particularly in middle-aged folks. It can be related to, maybe if we talk about more happening in women, is there a genetic predisposition? Is there familial predisposition? Is it related to hormonal change, perimenopausal situations? So there's a lot of nuance to this diagnosis that may or may not cloud your ability to diagnose accurately Meniere's disease. So that said, though, comes back to the timing. So you should determine if patients meet the diagnostic criteria for this when you're assessing these folks. Okay. So in addition to things you'd want to ask about triggers, timing. So these are per the Baronet Society. So greater than 5 episodes with vestibular symptoms of moderate to severe intensity, lasting 5 minutes to 72 hours. So you can see you have a broader range there than Meniere's in terms of the duration of the symptoms. And then maybe a current or previous history of migraine per the classification. One or more migraine features with greater than 50% of those episodes. And those might include headache with at least two, like unilateral location, pulsations, moderate to severe pain, aggravation with routine activity. They may or may not have photo or phonophobia with or without visual aura. And then, of course, they always say better accounted for. This is just a little caveat to say that they haven't been diagnosed with a stroke or some other finding. So you can see that there's a nuance. There's definitely overlap here with what we describe as a Meniere's disease criteria. So again, this is where it kind of muddies the diagnostic waters a little bit, where you're trying to really pinpoint the patient down. And many patients may not be able to give you this detailed information, right? Because if you've ever had a vertigo attack, it could be so just incapacitating. They're not thinking about what their ear is doing in the middle of a big vertigo attack. They're not like, I can't remember if I heard roaring tinnitus or fullness, or I can't tell if my hearing fluctuated, or, that's kind of going to survival mode, because profound vertigo can be quite unsettling, right? So, all right. So you have a 60-year-old comes to the primary care's office. Oh, and so I'm sorry, you mentioned a couple of quick things before we move on. So you mentioned neuritis. Um, how do patients with neuritis typically present, though? Is that a fluctuating thing that comes and goes? Or if somebody had first of all, what's the difference between a vestibular neuritis and maybe and a like a labyrinthitis? And then secondly,
Um,
do they present with episodic spells?
No, they don't. They have constant vertigo, and usually they are much sicker. Usually, these are patients that are much sicker, vomiting, quite uncomfortable, cannot move on their own. So, usually, when they come in, they're much sicker. Sometimes you might be able to find a trigger, either an ear infection or a previous upper respiratory tract infection in the days prior to onset of the vertigo. But their vertigo is continuous. It's not episodic, and they have other severe associated symptoms, like they're going to be vomiting all the time with a lot of nausea, and with vestibular neuritis, labyrinthitis, usually there is a risk that the days prior either they had an ear infection or an upper respiratory tract infection, which is commonly the trigger for the infection in the labyrinth.
Mhm. Yeah, you're absolutely right. So these are called crisis events, right? These folks wake up, they're spinning like a top, they're vomiting. Usually it culminates in an ER visit, and they get medication, central vestibular suppressive meds, and then they either have with or without hearing loss. And then most of these folks, again, after, because this is a peripheral vestibular insult, what do you think you might see in the acute phases, Amina? If I had a right ear like vestibular, like a labyrinthitis, for example? What might you
Okay.
find what might you find on my clinical exam um, that might be in the acute phase?
So in that acute phase, they're going to have features of vestibular hypofunction on the right side. So they will have a right beating nystagmus with the first component to the left side
Mhm.
that might be gaze evoked or even spontaneous nystagmus.
Yeah, so you said it would be
Or
a if I had a right hypofunction, I'd have a left beating nystagmus, right? The fast phase in direction of the
the
left,
first phase will
right?
be to the opposite side. First phase will be to the opposite side, but
Hmm.
the nystagmus will be worse when looking on the right side.
Hmm. So then the
So
nystagmus
on
is
the
named by technically it's named by the fast or the slow phase. I
by
mean,
the
technically
fast,
the nystagmus is what? Is it the true nystagmus is we name it for something, but is it what's the true nystagmus though?
we name it by the recovery phase, by the fast phase.
Say that again. I didn't quite catch it. I'm sorry.
We name it by the fast phase. So if I
Right.
have right hypofunction, my
Mhm.
fast phase is going to beat towards the normal side,
Right.
the opposite side.
Hmm. Correct. Right. So
Um,
it portends the brain might be thinking that the head is moving left, the eyes drift to the right, which is kind of the response, but then it snaps back to the left, right, to reset. And then
mm,
that's what you see. Now, what if I looked in the direction of the fast phase? What might I expect to see?
so if you look in the direction of the fast phase, so in
Well,
this case, if the patient is looking on the left, the nystagmus the intensity will reduce.
will it reduce or increase? And what is that called?
I forget what it's called.
So if I look in the direction of the fast phase, the frequency of the nystagmus should increase, right?
Yes,
You
that's
recall
one of Ewald's laws.
Alexander's law. Do you recall that?
Alexander's law.
Right. So when you look in the direction of the fast phase, I should have an increase in frequency of the fast beats, right?
Yes.
Right. If I look away and I still have beats, many times we'll see it after acoustic neuroma. We'll talk about, that's a third degree nystagmus, right? Which you can see. But if I look in the direction if it's direction changing, that's more central concerning, right? So if I look to my right, all of a sudden it's beating to the right. That would be concerning. That might tell me it's more central versus peripheral. Is that
Mm,
right?
yeah, yeah.
Yeah. We'll go through this again. We're at the end of the month. We're going to do some bedside, chairside, vestibular stuff.
Okay.
Okay. Anyway, well, good. So, all right. So I don't get too far off track with that, but okay. Excellent. So you have a 60-year-old comes to the primary care, random attacks of vertigo, lasts 3 to 4 hours, has concurrent ear symptoms unilaterally, fullness, tinnitus, subjective fluctuations with attacks that all clears with the vertigo. Okay. So what does it sound like to you? And then let's go through the questions. So what would you order any diagnostic testing to assess this person? First of all, what do you think that is? And then let's tackle for the first question.
Um, it's possible to be Meniere's.
Does it fit with the kind of clinical criteria?
It's probable Meniere's because it fits in less than 12 hours of random attacks of vertigo. He has oral fullness and tinnitus, and then also the subjective fluctuating loss. That fits with the Meniere's disease. What I'm not sure is how all the symptoms clear when the vertigo goes, even the tinnitus, right?
Mhm.
So I would still say it's possible Meniere's disease.
Yeah, I mean that fits pretty well with what we call definite, right? So if it's less than 12,
Definitely.
so 12, 20 minutes to 12 hours is sort of what is that kind of sweet spot for the vertigo duration. And then this is kind of a classic presentation, right? Because they have concurrent many times concurrent or just before ear symptoms, right? The fullness, tinnitus, hearing loss. And then those sort of abate or go back to their baseline. And we'll talk about that later. They could be a new baseline after the vertigo subsides. So, kind of somebody comes with this. This is kind of a classic presentation of it, right? Um, the challenge with timing is many patients, if they haven't established medications for abortive medicine, which we'll talk about later, it's hard to know truly the duration of the attack because most people don't just ride it out. Many times they'll have taken some kind of medication. So it kind of clouds that duration, but they may have already had a previous diagnosis that was accurate. Okay, so would you get any diagnostic testing?
So on the bedside, I'll do a tuning fork test.
Mm-hmm. Okay.
That gives us at least a baseline to compare with later. And in many years, I would expect the affected side, so if it's a right Meniere's, Weber's would be to the left, and on that side, Renee's would be positive.
Mm-hmm. Okay.
Suspect they'll have a sensory neural hearing loss. In many times, it's not possible to get diagnostic audiology in the emergency setting. So you go with your tuning fork in the first line and then schedule them for
Mm-hmm.
a definitive audiologic test
Okay.
in a days.
Right. So definitive hearing test is important. Absolutely. Yeah. Would you get any imaging for that patient?
No.
Okay. How about vestibular testing? Would you send them down for vestibular testing?
The vestibular assessment I would do would be bedside. I wouldn't send them for an objective vestibular exam like a VHIS or
Mm-hmm.
histopathography. I would do bedside vestibular assessment, and most importantly is just to rule out central pathology. There
Mm-hmm.
have also been a few reports where patients have BPPV on top of Meniere's. So bedside testing clinically is what I would do for the vestibular assessment. I wouldn't do objective vestibular assessment.
Mm-hmm. Okay. Good. Okay. All right. And we'll talk about education in a minute. Okay. Yeah. So key action statement 3, you definitely want to get an audiogram. Okay. And this is obviously really important to establish the baseline. If they haven't had an audio, you definitely want one because you need to establish a baseline. And you're looking for some specific features of the audiogram. And again, it's not a telltale, right? Because this is a fluctuating disorder. So many times, depending on when you capture the functioning of the ear at that time, it may or may not be indicative of those findings, right? So this shows a classic sort of a left ear low to mid frequency sensory neural hearing loss. But in some cases, the patient's ear may have recovered back to their maybe contralateral baseline or baseline in that ear that maybe was established previously on an audiogram. Regardless, though, it's good to have this because not only is it going to tell you the status of the ear, because you want to say, okay, is there objective change? Is there kind of room to salvage the hearing? And we'll talk about that in a minute with maybe steroids in the acute interval. But but it's going to inform you a lot about management of the disease later because as we'll see, if the patient fails first line therapies and they go down toward ablative therapies, a lot of the decision to instill an ablative option is dependent upon the level of hearing in the ear. Okay. So you're doing this for many reasons. One is you want to see the status, it can be diagnostic, but then you're thinking about functional capacity, but then you're also thinking about the way forward and what are your treatment options should they fail more conservative measures. Okay. All right. So the utility of imaging, this was left as a you could offer an MRI for the IAC to look at if once you've verified that there's an asymmetric sensor neural loss. This is always an interesting discussion because one is, particularly in the United States with the medical legal environment, even though if it's pretty classic that they have this fluctuating problem, some would say, well, you don't necessarily get the MRI, but certainly you don't want to be the person that misses the acoustic neuroma. So, so this would be one of those things where you probably get some variability in practice patterns. Brad, quickly, would you get an MRI in these patients? Or would
No.
you? No, you'd wait. Yeah.
Yeah.
Yeah. So you can see
So
that
for
there's
us,
some.
for us, because the waiting time either way is quite long,
Mhm.
wouldn't order the MRI immediately, and the resources are limited on how urgent the MRI is, so wouldn't ask for an MRI immediately. Even back in Uganda, would manage you first, and then if something is worsening from the
Mhm.
best we had, then we can motivate for the MRI.
Yeah. Yeah. So yeah, so this is an ongoing area, and what will be interesting to see is with the sophistication of the MRIs getting better with the stronger Tesla magnets, with the capacity to see more detailed anatomy of the inner ear. People are utilizing it in more of a diagnostic rather than sort of a rule out uh, format, which will be interesting to see. Will the standard of care sort of force our hand to get MRIs with higher Tesla magnets to confirm diagnosis? So well, that remains to be seen, but that'll be interesting. Yeah. Okay. Good. So vestibular testing, you should not routinely order vestibular function testing to establish the diagnosis. This is not indicated now. There will be some roles to be had later, but not in the acute or early phase. So this is not something you would do. As you mentioned, Mana, you would do your bedside vestibular exams. Certainly, you're looking for peripheral vestibular weakness. You're looking to rule out central causes. You're looking for vertical nystagmus, direction changing nystagmus, nystagmus that does not suppress with visual fixation. These are all things that you would definitely do at the bedside, but you don't need to send somebody to the formal vestibular lab for that. Okay. Yeah, good. And then, of course, education, right? So education is key on this. So if you are able to make the diagnosis, if they present with a case that's pretty clear cut, you really want to spend some time talking about some of the pathophysiology. Granted, we don't completely know it for sure, but we think that there may be some fluid dysfunction, osmotic, hydrostatic forces in the inner ear that could be related to sodium. So that's why we target things like diet, sodium restriction. And mind you that unfortunately, the data to date is not really ear-specific sodium recommendations, right? We make those sodium recommendations off of the American Heart Association. So we don't, that study really hasn't been done, which is sorely lacking in the field, is to truly understand what is the daily allowance of sodium that should be observed in these folks. And so, but you're going to talk about, you know, journaling, symptoms, the approaches, and we'll talk more in detail about this as we come down the wire here. But education is very critical about this to empower people to read and to implement some measures early on in the symptom in the disease process. Okay. All right. So 45-year-old comes to ER, primary care, spontaneous vertigo, fullness, tinnitus, fluctuating hearing loss, no significant medical history, no other symptoms. How do you proceed here, Amina? In terms of the acute phase, anything
So,
you're going to do for this patient right away? Let's say you're seeing them at the bedside.
okay, when you say exam is otherwise normal, is that the
Yeah.
other systemic exams or vestibular
Yeah.
exam?
Other head neck exam is pretty much normal. There's no otitis.
Okay.
There's no there's no other cranial nerve neuropathies.
And what's the duration of the vertigo?
It's it's well over an hour.
Over an hour. Is this the first episode she has had, or have we had previous episodes like this?
Previous episodes, yeah.
Previous episodes.
Mhm.
Any nausea and vomiting?
Just nausea.
Okay, so from the presentation above, it seems like this could be Meniere. So I would want to do a tuning fork exam and a bedside vestibular assessment to rule out a central cause.
Mm-hmm.
And then for the management, we are going to manage the acute episode. So if she has nausea, we'll give antiemetics for her. Many of them usually come in, they have vomited, we'll get an IV line and rehydrate them. Benzodiazepines have been reported to work for some patients with the acute episode. So something like lorazepam or clonazepam that is not so sedating, but gets the patient to rest in bed as we observe progression of the symptoms. And then once the symptom has abated and the patient is better, we can allow them home on an antiemetic, and sometimes we'll give a small dose of a benzodiazepine for the next 2 to 3 days if they still have if they still feel like they are dizzy. There are some drugs that have been shown to help, but in the longer term, like the benzodiazepines, like the beta histone, sorry, like beta histone. Some doctors use it, some don't, for
Mhm.
the long-term prevention of episode recurrence. And we can give 16 milligrams 8 hourly, and then
Mhm.
review the patient in about a month. In some settings, they also give thiazide diuretics, so bendromethiazide or hydrochlorothiazide, small doses, but this needs to be, we need to be cognizant of what the blood pressure is so that we don't give the patient hypotension. If the patient is already on hypertensive drugs, antihypertensive drugs, then we can always discuss with the physician so that they are on a regimen that contains a thiazide diuretic. We would also prevention, the second question, prevention of attacks in future. There are things that they can do from their diet, so avoiding high levels of caffeine, chocolates. There have been some types of cheese that have been reported to trigger episodes of Meniere's. Would also tell them to reduce how much salt they take in their food. Stress has also been implicated in triggering these episodes. And then I would want to see them maybe in a month and reassess their busy journal, how many episodes they're getting, what's the duration of the episodes, and what are the symptoms they feel with the episodes. If they feel the hearing is worsening, then we can repeat the hearing test in a month, the formal audio in a month.
Okay. Yeah. Good. So, yeah. So acute vertigo attacks, you're looking at trying to shield the brain from what's happening at the ear. So central vestibular suppressive meds. And you mentioned a lot of these meds, like, the benzodiazepine family, and some others, which we'll talk about. But you definitely would want to offer a limited course of vestibular suppressants, okay, to patients, right, to stop the attack, right? You just want to, you're not necessarily thinking about long-term control at the moment. You're just trying to get that patient through that moment. And so other meds like antihistamines, like meclizine, the benzos, you mentioned that, anticholinergics like scopolamine. The phenothiazine family, so you're talking about compazine, Phenergan, those are highly effective. And then there's a medication called droperidol, which is IV. That's kind of like your last source. So those all meds work centrally to suppress the vestibular centers of the brain to shield it from the ear. Um, if someone if they have a vertigo attack like this, like Meniere's, is Zofran or some of these GI nausea meds necessarily going to curb the nausea?
When you think of the pathophysiology, no, because they will prevent nausea, but they're not stopping the cause of the nausea because it's a vestibulogastric reflex that is giving them
Right.
the nausea. So if you suppress the vestibular system, you are able to turn off the reflex.
Mhm.
My question would be, in sometimes, especially back home, we have the benzodiazepines, but are they sufficient to suppress the vestibular system enough to avoid the nausea and vomiting that they have?
Yeah,
Meclizine
sometimes
is not able to
there's
answer.
sublingual formulas that you can give. I kind of like Ativan. It's fast on, fast off, for that. Some meds can be given under the tongue. Some are sublingual. They'll dissolve so that they don't, because sometimes people will take the med, then they'll vomit, and then they won't actually get the medication impact. But if it's refractory to that, then there's IV doses of medications that would be important to give. Yeah. But you're right. So things like Zofran work on like they work on the serotonin 3 receptor in the gut. So they really don't help, like you said, with vestibular-based nausea. They help with GI-based nausea, but they're not going to come. They may be given adjunctively, but not as a solo medication. Yeah. So again, this is about educating to prevent recurrence and prevention, and then for prevention. So you're talking about dietary lifestyle modifications. Again, sodium restriction, specific diet triggers if they've identified them, allergies. There's some link to this. Of course, stress reduction. Those are all important. Um, so for maintenance therapy, this is where we talk about in addition to the diet restrictions, which we just talked about with sodium, usually we recommend, 2,000 to 2,500 milligrams of sodium a day. It's a tough diet change for people. Most people have a high sodium diet or higher if they eat anything, if they eat out at restaurants, if they eat anything processed, packaged, canned, most of that stuff is loaded with sodium. And so I always tell patients, I say, you need to record the next 3 days of what you're going to eat and get a number, milligrams of sodium per day, and then try to cut that by a third. I try to be realistic with a end goal of about 2,000 to 2,500 milligrams. And again, that number is based on our heart association data. We have no real strong data for the ear specifically. But of the two, I always tell them, I say, you can add a diuretic if you fail despite a stringent sodium restricted diet, you're continuing to have attacks, then I would add a diuretic or beta histine. Beta histine is not always available in pharmacies throughout the world, particularly the US. Yeah, there's some pharmacies, compounding pharmacies that'll make it. It's more readily available, say, for example, Europe, etc. But it still can be made available. So the choice there is I would say, provider dependent. Some people go with a diuretic first. Some might go with beta histine first. Some have added those together. But again, I don't usually go to that right off the bat unless they're failing a sodium restricted diet because many have argued that of the two, the diet is more important than the diuretic. If that makes sense. Brad, do you have any thoughts on that? How you manage that?
I usually put them on a low salt diet and a diuretic, and
Mhm.
I usually shoot for 1,500 milligrams a day.
Yeah.
I
So pretty
tell them
tight.
if the food tastes good, don't eat it. So it's got too much sodium in it.
If you're getting any enjoyment out of eating, you're doing it wrong.
That's exactly right. Yeah, yeah. Pretty
It is,
soon
it's
their
hard.
diet
It's really hard. It's a hard diet for people to adhere to.
their diet becomes more problematic than their vertigo, and then when they relax their diet, they're happy, even if they
Yeah.
still have vertigo.
Yeah, right, right. Yeah, the trade-off, right? Yeah. Do you use
Yeah.
beta histine ever?
No, I don't.
No.
It seemed like my friends that lived up north often could get it from Canada. I don't know if you
Yeah.
had people getting it from Canada when you were up there,
Hmm. Hmm.
but I haven't really used beta histine. I don't like it as a first choice only because people get so quickly. It seems like antihistamines lose their effect over a shorter
Hmm.
period of time and have a higher incidence of somnolence with the elderly patients. And so I try to I like a diuretic better, but
Yeah. Yeah. Gotcha. Yeah. Okay. Yeah. So you can see there's variability here. And this is where it lends a lot of opportunity for a little better research from our standpoint on efficacy and strategy. But there's definitely variability there.
I have a question
Yeah.
for you. Do you start the diuretic? When do you start the diuretic? Is it after the acute episode has aborted? And what's your preferred drug for the diuretic?
Go ahead, Brad. I'll let you comment on that first.
I usually use diazide, which is a combination diuretic. It's got a hydrochlorothiazide in it, and something else. One of them preserves
Triamterene.
potassium. Yeah, triamterene. Yeah, thanks. Triamterene, which one waste potassium, the other one kind of hangs on to it, so it balances that out. Sometimes I'll have them check their potassium after they've been on it for a couple of weeks, make sure that they haven't dropped their potassium too low and have to have a potassium supplement with it. But I usually start with diazide. I may put them on a low salt diet alone first and see if that makes a difference over a month or two. And if it doesn't, then I'll add the diazide.
Yeah. Yeah, that's what I do. I mean, I usually start with the sodium restriction and then add diazide. If they fail that, then I might think about beta histine. I might try something, but it's pretty rare that I go that route. Yeah.
Okay.
Okay. So 45-year-old, again, recurrent attacks, has a diagnosis of Meniere's, despite sodium restriction and the diuretic / beta histine. And then she has usable hearing and doesn't want to lose that. Meaning usable, sometimes, again, you have to define what usable is. Many times the people will define it as a, pure tone average of less than 60 dB with at least 60% word discrimination. But again, usability, quote unquote, usable is really, I think, a patient-centric decision, right? Some people who we might not think per parameters would not be usable are like, no, I'm actually getting a lot of hearing out of that. So I'm very careful about how you define what is usable. Okay. So if someone's they're still having attacks. So basically what you're getting here is they failed first line therapy. You have somebody who, despite being stringent on the sodium restricted diet, plus a diuretic and or a beta histine, continues to have attacks, but has reasonable hearing. What other options would you provide for this patient now?
So the next step I would consider now would be to offer them intratympanic steroids.
Mm-hmm.
Preferably as high as you can. I think Dr. Welling told us he has access to 24 milligrams.
Mm-hmm.
But what we have in Uganda is 8 milligrams. So if the higher the concentration, the less you need to repeat. So if you have 24, even 12 milligrams intratympanic steroids, you can do it as an outpatient. We don't have pheno, but if you have pheno, you can numb that area of the ear with pheno. We don't have pheno, so we'll do local anesthesia around the ear, put a ventilation hole, I'll call it hole, small hole in the anterior superior quadrant, and then go ahead to inject the dexamethasone into the middle ear. Ask the patient to remain lying on their side with that ear up for at least 30 minutes. Usually this is enough to control the Meniere's. If you have a high dose concentration, what we have here in Cape Town is 4 milligrams. So we will repeat the injection in that same week. We'll repeat the injection every 72 hours. So that at least at the end of the day, the patient has received 12 milligrams of the dexamethasone. I've read some papers about doctors, I think mostly research-based, talking about putting in a bromate, but there is no literature to show that that is superior to just doing an injection directly into the drum.
Mm-hmm.
There are also some papers that question how much of that dexamethasone actually gets into the middle ear, the inner ear via the round window, given that we know there is a membrane, and in some patients there is fibrosis in that area. But most people will just put the injection and then give the patient time. If the patient is okay, they don't need to come back. Many people need to repeat the injection maybe after a few months or a year, depending on how the symptoms of the patients are. For most of the patients you've seen here in Cape Town, they actually go up to a year or even more with either no symptoms or very minimal symptoms, that they don't need to come back to the hospital to us for repeat injections. Meniere devices, the verdict on this is some surgeons still use it, many don't offer it commonly anymore. It's also not readily available in many centers. And then option C for non-ablative surgery. So non-ablative surgery means it's invasive, but we are preserving hearing. So here would consider endolymphatic sac decompression. However, it wouldn't be first line. This is if someone has not improved on multiple doses of the intratympanic steroids. Patient needs to understand that this involves surgery, so we'd have to do a mastoidectomy, find our labyrinth, the lateral and posterior canals, and then estimate where Donaldson's line is, and inferior to that is where we'll find our endolymphatic sac. There are different techniques. Some people put a shunt, some people will decompress it, some will open it, and it is surgeon dependent. Papers report actually good outcomes with endolymphatic sac decompression. It's just technical and you need to know how to do it. Other non-ablative options that have been reported, not so popular anymore, but singular neurectomy. But it's not so popular anymore because it's invasive and it requires, it poses different risks to the patient. So most patients are going to be offered steroids, and if that doesn't work in a good center, they can be offered endolymphatic sac decompression.
Okay, good, nice work. Brad, quick, would you of these options, how would you proceed?
Yeah, I go with steroids, and if that didn't work, I would consider an endolymphatic sac shunt. I think the old singular nerve neurectomy was used primarily for persistent BPPV because it didn't really affect the horizontal canal, only the posterior, the saccule and the posterior canal. And there was a high incidence of sensorineural hearing loss with it because the approach was complicated by getting the saccule in the way. But yeah, I agree with trying steroids first, and then if that doesn't work, then consider a shunt.
Great. Yeah. So positive pressure therapy, the data is pretty clear that this is not very effective. So people have shown over time, despite a couple of reports that showed some benefit overall, the really systematic review and randomized trials show it's not really effective. And I've had personal experience with a couple of patients with this. It didn't really work. You have to put a tube in the ear, and it's this micropulse generator that is thought to maybe reset some of the pressure forces in the inner ear, but it's really not shown to be very effective. So even though it's relatively conservative approach because you have a tube, not recommended. Intrahepatic steroids, yeah, you can offer this. We don't know the duration of long-term efficacy of this, but certainly in the setting of trying to preserve someone's hearing, this is definitely a reasonable way to go. It really depends on how often you're going to give the injections, right? So are you going to do it one injection weight based on symptoms? Again, this tough thing to study because the variability in application and scheduling for this. But again, it does have a place. I think it's just a challenge to really standardize the approach. Now, gentamicin, we didn't talk about this, but gentamicin really has supplanted surgery for Meniere's disease in that when you're talking about a vestibular chemical ablation of the chemical ablation of the vestibular end organ, with really less than 10 to 15% impacts on hearing, it's really become a bit of a magic bullet for Meniere's. The problem with this is it is ablative. You are ablating the vestibular component. You need to know that the contralateral ear is healthy before you do this. And the issue is the hearing still is at risk to some degree. And then the problem is you don't know the endpoint, right? So many patients, what we don't talk about, the elephant in the room with Meniere's disease, is the stress of when an attack can come. So a lot of patients, when they have Meniere's disease, they're afraid to leave the house. Because they're like, oh, I don't want to go anywhere because if I have an attack, I don't want to be vulnerable in public somewhere, driving. And that's really restrictive socially, psychologically. And so while IT gent is very effective, the endpoint is unclear. So patients sometimes aren't willing to absorb that sort of uncertainty and say, okay, yeah, you're doing something for him. Is it going to work or not? And then they still have this pins and needles sort of thing. But Gent is certainly has become something that is much more mainstream because you can do it in the office, you can repeat those doses, um, and take it from there. Your patient doesn't actually have to go to the OR. So
I
and
would
then yeah, go ahead,
I would
Brian.
just add that with gentamicin, I have tried to be as conservative as possible in the sense that I don't try to ablate the caloric response. I'll just give them one dose and see how they
Okay.
do. And
Yeah.
over time, if they need another, I'll give it to them. But
Hmm.
I know some people have a goal of ablating any kind of a caloric response with their gentamicin injection, and I think
Yeah.
that it increases the risk to hearing a little bit if they have any useful hearing, and it also is not
Hmm.
necessary a lot of times to completely ablate the vestibular response to have it be effective.
Yeah. That's a great point. Yeah.
I
Yeah.
have a question.
Sure.
There is a surgeon that I think was discussing if adding sodium bicarbonate to the gentamicin increases its efficacy and absorbability to the middle ear. I
Adding
think
what, Amina? I'm sorry, I didn't catch. Adding what to it?
sodium bicarbonate
Oh,
into the gentamicin to reduce
yeah.
the discomfort the patient
Yeah.
gets, but also to increase its absorbability into the via the round window. Do you do that?
I don't personally. Whenever I've done gent injections, I just take the gent itself. I have never done that, but so I don't have any experience with it.
I have done it early on to try to, I thought the idea was, I didn't realize it was to improve the permeability. I thought it was more to make the pH more compatible and make it sting a little less when you put it in.
Hmm.
But yeah, I mean, I don't routinely do it. Actually, I don't do much injection anymore. So
Yeah. 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 So I think it's unclear on that.
Okay.
But
can I
yeah, but there, oh,
can
go
I
ahead,
add
Brett.
one other thing?
Yeah.
When you asked me about imaging, I don't routinely do MRI imaging when somebody comes in with a classic uh, picture of Meniere's. But if they've had recurrent problems and you're considering gentamicin or some other type of ablative therapy, I do think it's reasonable to image the endolymphatic sac and see if they have a hypoplastic sac or they have a degenerative type pattern because and you can look at both sacs that way and get an
Hmm.
idea since the hypoplastic sac tends to be more often associated with bilateral disease, and I'm a little less aggressive when I think they're going to get Meniere's in the other ear. If they have a
Hmm.
degenerative pattern and a more acute angle where the sac goes into the duct, then uh, I think that I'm a little more likely to use ablation. I do think there's some association with the endotype, whether they have a hypoplastic or a degenerative type of a sac.
Hmm. Yeah. Interesting.
It's kind of comes out of the temporal bone lab, the work from
Hmm.
Andreas Eckert at our place, looking at that.
Hmm. Hmm. Yeah. That's interesting.
And the other thing, in terms of just research, I think that, and it's probably helpful diagnostically too. In addition to um, the other historical criteria, it is kind of nice to demonstrate if they have endolymphatic hydrops. If you're going to, give them contrast or use a T2 weighted FLAIR
Hmm.
image and see if you can detect that they have hydrops, I think that may be may be useful, but I don't necessarily do that on the first pass, and I don't do it for everybody that's got Meniere's.
Hmm. Yeah. Yeah. It'll be interesting to see how that evolves over time with enhanced imaging. Yeah. What the application will be from the get-go or not. Yeah. Yeah. So, I know we're getting close on time here, but so someone who has a similar person who has really significant drop attacks, right? So they've had maybe in previous steroid injections, they've had maybe gentamicin, still having a lot of drop attacks. At this point, the kind of the gold standard really is surgical ablation. The old standard transmastoid labyrinthectomy. I think that's become more probably more palatable lately because of our opportunities now to put cochlear implants into the same setting. So I think this offers a couple of things that I think are advantageous to patients. One is you have a definitive time point knowing that if your diagnosis is correct, again, you're presuming everything is correct and this is the diseased ear. The minute you ablate that ear, the dynamic lesion is now static. It's done. That's it. And patients, I think, can draw some psychological relief from that endpoint, that finite sort of quality of this intervention. But now with our enhanced capacity to get implants in at the same setting, I think it's even made it a bit more attractive beyond that. So I think this has kind of revolutionized this as the gold standard where, you surgical ablation, it's done. You got to remove all the neuroepithelium and then put an implant at the same sitting. And I've had many patients do very well with this dynamic where they have the psychological relief, there's no more attacks, and again, assuming that the contralateral ear is fine, they have no other issues. But then to regain some usable hearing is really kind of a bonus for them. So
I think the key there is whether or not they have pretty good hearing going in. If they do, you might want to consider vestibular neurectomy because the
yeah.
risk of hearing loss with a vestibular neurectomy is only about 5%. If they have poor hearing or non-functional hearing, then labyrinthectomy is certainly more straightforward, and adding a cochlear implant is a great boon to it.
Yeah. But absolutely right. And that's the patient selection here is usually they're in that non-usable place where this is a lot of shared decision making because I'll have some folks that still have reasonable hearing and I'll give them the options and let's say, you know what, I don't care about the residual hearing I have. I can't have these attacks anymore. I don't care. Just take it away, stop this, and put an implant in. It's fine. So you really have to have a good, frank discussion and have a good like a team decision-making dynamic before you make these decisions. Because again, this is an irreversible thing. You can't take it back once you've done this, much like gent. Now, the interesting thing with sac surgery and vestibular nerve section, which as we come here, sorry, I'll get through this real quick. So lastly is vestibular therapy. Obviously, you've got to have rehab, right? So if by nature of the disease, you're going to have a peripheral vestibulopathy, but if depending on what you do beyond that, that patient's going to have unilateral weakness that's going to require vestibular therapy. So that is definitely something you have to do. And so let me keep moving through here. And of course, assistive hearing technologies, if they have some usable hearing or not. And then of course, outcomes you want to document. So this is the nice algorithm that you can kind of use as a flow chart to kind of walk you through management of these folks. The one thing that we could not as a guideline committee comment on was vestibular nerve section and lymphatic sac surgery. The reason why is as a group, we couldn't formally make recommendations was because the data is not very standardized in those fashions. So it's not as clear cut as gent and studies that have been done with gent and labyrinthectomy. So it doesn't necessarily obviate those as possibilities for treatment. It just means that the standards have not been really well set because of the nature of those procedures. Like you said, some people just decompress the sac, some people open it, some people just shunt in there. Those studies haven't really been well done to say one is better than the other. And so I just say that that's like the disclaimer.
I hate to leave, but I forgot I've got a 7:30, so I'm
You have to get going too. Yeah. Thanks, Brad. We'll see you next Friday. Thanks so much.
Bye-bye.
See you later.
Thank you.
Dr. Willie.
Have a good weekend.
Thanks.
Bye. Amina, questions about all that?
Um,
A
no,
lot,
thank you.
I know.
It was a good discussion, and it also gave, I think, a clear explanation because we had sent the guidelines earlier, but talking through cases was actually very nice to put things into perspective on what you would and wouldn't do for a Meniere's patient.
Yeah. Yeah. Well, you can see there's a lot of nuance to patient care with these folks, right? It takes time. Many times it can take many months to make the diagnosis, right? And so it's not always cut and dry. It's always straightforward. You have to um sometimes it takes time. But you really want to be thoughtful about what you do to folks, especially if it's irreversible, things you can't take back.
Yeah, but it was a good discussion, going through the guidelines, but also talking through cases. I think that helps you conceptualize the guideline and what you do when you actually have a patient in front of you. So thank you. It was a
Yeah, you
great.
bet. Absolutely. So next Friday, Dr. Welling then will talk about his facial nerve